So, good afternoon, everyone. At the outset, I take this opportunity to thank Dr. Kumar Prabhash, Dr. Anuradha, and Dr. Prateek for inviting me here today to share the experience of Pathkind, where sequencing of lung cancer patients is concerned. So, Pathkind is kind of a new entrant into this field, so I have limited data that I would be sharing. I think it would be fair to say that cancer is actually a disease encoded in the genes, because now there is ample data to support the fact that whether we talk about the uncontrolled growth or the drug resistance or metastasis, but thankfully also the fact of targeted therapy, it's all because of the genetic variants which are encoded in the genes themselves. As a laboratorian, the aim of genomic testing in oncology is, of course, to identify actionable targets as well as resistance markers so as to enable the medical oncologist for better patient management. And that is really what we focus on. For lung cancer, at a minimum, as per NCCN, whatever panel, whatever standalone testing is used should ideally cover all these important biomarkers and mutations. So in line with that, in our laboratory, primarily most of the testings that we do are NGS panels. Having said that, we are limited as a standalone laboratory not only on NGS, but depending upon the patient requirement, we also do specific standalone biomarker testing either using ddPCR, ARMS-PCR, FISH, or IHC. An important case in point is PDL1. As of right now, at least in our laboratory, we are offering PDL1 testing only on the tissue sample. So hence just the IHC based. Which brings me to the fact that really whatever technology we use for oncology, for somatic mutation testing, tissue really is the issue. Whatever recommendations, guidelines we look at, they very, very clearly underscore that this is the gold standard. The testing ought to be performed on tissue until and unless you have a scenario where the biopsy is either not possible, it has been exhausted, and only in that case we resort to using the cell-free DNA or the liquid biopsy. The smallest lung panel that we use in our lab is the 12-gene panel, and we use the platform, the S5+. So the iron torrent platform is what we use, and we perform a combined DNA RNA testing for this panel. The largest, and this is actually the panel which gets referred more often. So the bulk of the data that we have from our lab is from the 52-gene panel, which covers the relevant hotspots, the copy number variations, as well as the gene fusions. The earlier panel that I had shown, by and large, in terms of the copy number variation, it only focuses on the MET. So we know now that the ERB2 copy number variations are also important, which is not covered in this panel, but in the 52-gene panel, the ERB2 copy number variations are also covered. For patients in which the cell block is cell or the cytology block is either not available, and we are going ahead with testing using the cell-free DNA, the Oncomine cancer panel is what we use. And in terms of the genes, the coverage, pretty much it is like, a sort of copy of the 52-gene panel that we do for somatic mutation testing. So this is, this particular year, we processed 564 samples for tissue biopsy for lung cancer, and of these, 81.6 were adenocarcinomas, and only about 11% were squamous. There were 7% which were categorized as poorly differentiated carcinomas, and 2% were small cell lung carcinomas. So this was the histological distribution of the samples that came to us. Demographically, there were 61% which were male and 39% female. And age-wise, we got most of our samples which were in the 5th and 6th decade. And overall, we were able to identify variants in about 88% cases. There were 2.6% in which the results were either unsatisfactory or we could not perform testing, and about 9.9% in which no variants were identified. Of these 88%, there were 71% which were informative variants in terms of being able to help the clinician for targeted treatment. And between the various histologies, I have provided what is the percentage in which we were able to identify any variants at all and versus not. So if we look at, though it on the face of it, it looks as if like, in the squamous cell carcinomas, we are able to identify less number of variants, but then there might be a skew therein, because if we look at the total number of cases which were squamous in the population that we had tested, these are only about 50, 60 cases. So there could be an inherent skew because of the small number of sample size that we had for squamous. This is the distribution and frequency of the variants that we saw amongst the adenocarcinomas. And in this, we were able to identify variants in 91.2% cases. As has been shown by other speakers also, and in concordance with the already published literature, the largest mutation positivity was seen in EGFR, which was 41.3, followed by TP53, RAS, ALK, and so on. There were 9% cases in which we saw double mutations. And most of these were combination of two different kinds of EGFR mutations, or EGFR with MET, EGFR with CTNBB, PIK3, TP53, and also combinations of PIK3 with KRAS, and combinations of ERB2 again with ERB2. So two different kind of mutations, point mutations as well as amplifications in this. There were other cases, 2.4%, in which there were more than, so there were triple mutations and beyond that. This is the scenario that we had for adenocarcinomas. Amongst these squamous cell carcinomas, 20% cases we could not identify any variants, and the largest, so this again is just to show that amongst the EGFR mutations, the highest percentage of the subtype that we saw was exon 19 mutations. For squamous cell carcinoma, the highest percentage of variants were seen in the TP53 gene, followed by PIK3 and FGFR2 along with TP53. In the TP53, which was the highest one here, we saw that the maximum number of mutations, which primarily were single nucleotide variants, these were seen in exon 5 and exon 7. So by and large, this is like, the data that we have. We did process about 50 odd samples for liquid biopsies as well, but the data was kind of all over the place, so I'm not showing that here. So limited data, but it's a start that we have made at Pathkind. So thank you. Any questions?
In one of your
Yes.
you showed about the quad.
Yeah.
Mutations, and so
Correct.
what were they, and did you take a follow-up with the clinicians? How did they take this
So
patient?
the quad one is actually rather recent ones. you know. So in fact, but for the double mutations, yes, we have a follow-up of that, as we do for the triple, not for the quad as yet. We have reached out, but we don't as yet have information on that. But it was, from what I recall, it was a combination of EGFR, TP53, along with CTNNB1, and I'm forgetting the fourth one.
Your total proportion of double mutant is also
About 9%.
very high. So is this only EGFR double mutation or EGFR with all genes?
No, so EGFR with, so they're like, three main ones. EGFR with some other genes which I've listed out here, TP53 with a combination, and PIK3 with a combination, and ERB2.
Okay.
So four of these
Four
with
genes.
combinations of other genes. Thank you.
Thank you, ma'am.